Hello, I'm Don Deemer. I'm going to do an abdominal exam on you today. All right, very good. So the first thing I would do is observe and inspect the abdomen. Try to do that with tangential lighting if possible, but looking at the contour of the abdomen, also looking at color, pigmentation, looking at for any striae, any scars, any tattoos, looking for any pulsations, visible peristalsis, and whatever else is on that list of things you need to memorize, okay? All right, so we inspected all of that. But first, though, we draped him appropriately, right? From the xiphoid process down to the suprapubic area. Now we're going to auscultate the abdomen. So make sure when you're auscultating to always put these in your ears, okay? Tap on the side that you're going to use, and we're going to listen first at all 4 quadrants. All right, so. Okay, so he had positive vowel sounds in all 4 quadrants. Now we're going to listen for bruits in the abdominal arteries, all except for the femorals, which I'll do when I palpate at the end. So I'm going to listen to the aorta for any bruits. And it's hard to hear over all the borborygmi. Renal. Iliac. And I didn't hear any bruits, okay? All right, so the next thing we're going to go to is percussion of the abdomen. And I'm first going to percuss all of the quadrants, okay? So, okay, the abdomen is tympanic in all 4 quadrants. Now I'm going to try to determine the size of the liver by percussing, okay? All right, so we're going to start in the midclavicular line, somewhere around below maybe where the umbilicus is or umbilicus, and then percuss upward, okay? Changing something? All right, okay. So if you had a marker, you would mark it right there. I don't, okay? So mark, and then you can come up in an area that we know is going to be kind of resonant like that, and percuss down. Definitely different, right? Okay, so you'd mark that, measure it, and then say how big it is, okay, in centimeters. Okay, so the next thing we're going to do is percuss the spleen. Okay, taking this hand, put it over here on this side of the patient, lift up a bit. I'll do the lifting, it's okay. No, it's okay. Take this right hand, right here. Okay, now take a deep breath. What am I doing? Palpating the spleen. Spleen, there's no splenomegaly. Now we're going to percuss. Lowest interspace. Okay, and take a deep breath in. Still tympanic, right? So the spleen remains tympanic. Now we're going to have to move along to palpation of the abdomen. And the first thing we're going to do in palpation is to do light palpation. So we're going to take our one hand and palpate in all the quadrants. And if you need to, he's got a pretty loose abdomen and I feel like I'm getting a good exam. I'm not going to do it, but you can lift up the knees, okay? That's helpful sometimes. But you got to remember to take them back down when you palpate the inguinal nodes and stuff, because that makes it difficult. All right? So there wasn't any masses, tenderness, or guarding to light palpation, and now we're going to go to deep palpation. So take the 2 hands, like that, in all 4 quadrants. And then we're going to go and palpate the epigastric area, palpate the umbilical area, and then the suprapubic area, okay? All right, so there were no masses, guarding, or tenderness to that. So now, to deep palpation, so now we're going to palpate the liver edge. So I remember, I don't have a pin, but I remember marking it there, so I'm gonna go below that, hand under here, take a deep breath. Okay, the liver is smooth and not very tender, right? You can feel it a little bit, okay? And now we're going to palpate the spleen, and I've already showed you this once on accident, but take a deep breath in. Okay. Spleen is non-palpable, and I'm going to now try to palpate the right kidney. So, can't feel it, and this exam is going to be on this side of the patient. And
sorry about that sweat.
And I also can't feel that. So now we're going to try to palpate the abdominal aorta, okay? And take your hand, and I can kind of see the palpation a little bit. You can get it on one side of it. Can you guys see that in there? Mm-hmm. Yeah, pulsating. So yeah, it's approximately 2.5 centimeters without expansion of pulsations. And now what I'm going to do is I'm going to palpate the inguinal nodes, the femoral arteries, and I'm also going to auscultate them for bruits. And if you don't mind, I'm going to be okay? All right.
I don't think we have gloves on the checklist. Do you care?
I don't care. I just do it.
Don't.
That'd be for me. Okay. There was no adenopathy. The pulses were strong and symmetric, and there were no bruits on that. Now, if there was a need to, or if I was looking for something specific, there's a group of special maneuvers that we could do to look for certain things. One thing you might want to do is to check for peritoneal inflammation. One way you could do that is by doing a heel tap. And a heel tap is just like this, okay? You can see how his abdomen shakes. Did that hurt? Okay. You'll want to check and see if that hurt. And then next we can check for rebound tenderness. So you do like we do in deep palpation. And does that hurt? Hurt when I let off like that? No. Okay. So no rebound tenderness. Another thing we can do, checking for appendicitis or even peritoneal inflammation in general, is ask to cough. Can you cough? Okay. Did you guys see him grimace or hurt, or did that hurt in any specific place? No? You can check McBurney's point for tenderness of the appendix. Does that hurt? No? All right. And we can do what's called Rosving's sign, and that's pressure with deep palpation on the left side to see if he has pain on the right side. Anything there? Okay, good. Now this is the psoas sign, and this is his knee right here. I'm going to put my hand right above it, and then I try to raise that up against my hand. Okay. That hurt? No, not at all. All right, now we're going to do what's called the obturator sign, so allow me to flex your knee up like this. Okay, and then we're going to internally rotate the hip. Any pain with that? No. So negative obturator sign. Now if you suspected acute cholecystitis in a patient, you could do something called a Murphy's sign. And with that one, put your hand in a similar place where we check for the liver, okay? And just a little bit medial to that, and then have him take a deep breath in, okay? And if that would make him catch his breath or act like the pain just really went through the roof, then that could be a sign that he has acute cholecystitis, right? And now, another thing we could do is check for ascites, and we talked about, some conditions that might cause that, but first, what you would do is look for that protuberant abdomen. It looks like acidic fluid, but he doesn't have that, but we're still going to try to map it out anyway, so and it's just really tympanic all the way. I mean, you can go all the way out to where the posterior structures start to be dull anyhow, so he doesn't have ascites by percussion that way, but to check for shifting dullness, to see if fluid would go down and gas would stay there, put your left hand up by your head right there and just roll over there towards the peeps, okay? And then you would percuss up there where it's tympanic and then percuss down. Okay, come back over. And then I think that I did not show you the hook method of palpating the liver, and I don't know if that's on
We also
special
have
livers.
referred rebound.
Okay. Is that on there?
It's on here.
All right. Now, taking your hands like this, take a deep breath in, anything there? And the liver is non-palpable that way to me. Okay, now we could try to do the scratch test. Place this over where we know we marked the liver was, and then gets really loud right there, where it is.
I used to do that a lot when I first was feeling livers. I'm not sure. Delineate the edge.
Right there. Same place that I percussed, just about. Okay, so that confirmed that. And now, another thing you might do is check for diastasis recti or ventral hernia, or any kind of defect here. And in doing that, you could ask him to raise his head up and shoulders up. Anything in the linea alba, and I didn't feel anything. I'll lay back down. And then if needed, you could do a pelvic or a rectal exam. We talked about a rectal exam, and if it was a female, if it's lower abdomen, I mean, it could be a lot of other things besides appendicitis and whatever. We learned those exams later on. And then referred rebound is checking for rebound sort of like with the Rosving sign. Okay, so you know how it hurt when you do rebound, and you ask if it hurts when they pull out. Now, when you do rebound over here, does it hurt over here on the other side or somewhere else? Okay, that's referred rebound. CBA tenderness. Yeah. Okay, can you sit up and swing your? That's not on there, is it? Is it?
I saw it.
It was in the lecture, but I think they moved it to something else. That's why it's
We
not.
moved it to the.
Okay. Don't worry about CBA. It's on the next exam. We took it off, even though it's in the lecture. All right. Did I miss anything? Anything? All right.